Cholecystitis refers to inflammation of the gallbladder, and it's very prevalent in the United States due to our diet and our affluence. The function of the gallbladder is to store and concentrate the bile to be released PRN after eating a fatty meal. And that's going to be important when you look at the timing of when somebody has colic of the gallbladder. So there's two types. There's cholecystitis due to stones and cholecystitis without stones. So without stones, it's called acalculous cholecystitis. And this is usually seen in patients who have some form of starvation, or they have high estrogen levels, or they're on TPN. So in instances where they're very sick and haven't been eating, they can have calculus cholecystitis. And then patients undergoing TPN are at risk because they have stases in the gallbladder, and that just allows it to become inflamed. And the most common kind, though, is the kind with gallstones, which are called cholelithiasis, and it's called calculus, which calculus means just like with stones. All right. So these stones result from chemical irritation and inflammation. Um, and it can obstruct the cystic duct, the gallbladder neck, and then the common bile duct. So patients with chronic cholecystitis, they have clay-colored stools due to biliary obstruction because bile obstruction prevents the bilirubin from entering the large intestine, which gives stool its color. So therefore, they're going to have clay-colored stools. The urine becomes dark and foamy because the kidneys attempt to clear the body of high bilirubin levels that happen with chronic cholecystitis or with biliary obstruction. And then the patients get very itchy. They have itchy skin when there is biliary obstruction because bile salts accumulate in the skin. And they also have jaundice because of the increased bilirubin. And then they're going to have an intolerance to fatty foods because of the lack of bile that they have. Okay. So who's at risk for cholecystitis, acute or chronic? So you can remember the 6 F's. Stands for fair, which means Caucasian women usually, 40, family, female, and fertile. So there is a genetic component to it. People who are sedentary after the age of 40, usually females who have had a few children or just had a child, they're going to be most at risk. Okay, some other metabolic risk factors include people with type 2 diabetes, elevated glycosides hemoglobin, that's your A1C, obesity with the BMI greater than 30, so that speaks to your fat, dyslipidemia, and insulin resistance, so people with metabolic problems. Older adults are more prone to cholecystitis because they have decreased contractility of the bile ducts. So they're going to be more prone to gallstones. And I don't even think 40 is old, but that's typically when people become more at risk. Weight loss, rapid weight loss is a factor in developing cholecystitis. And the reason is if somebody's on like a starvation diet or like the ketonic diet, or there's like all different variations of diets that result in rapid weight loss, like somebody that only drinks protein shakes, okay, it stresses out your liver. And when your liver gets stressed out, it increases the amount of cholesterol in your body, okay? So there is a correlation between increased cholesterol and gallstones and cholecystitis. Um, um, Not really sure what the mechanism that results in cholecystitis, but there is a correlation. The best diet for somebody at risk for cholecystitis, and probably most of us, is going to be low-fat diet. Okay, so eating, fruits and vegetables, good protein. Okay, the high-fat diet and low-calorie liquid protein diets are going to put people at risk for that reason I said before. Women are at risk because they have increased estrogen, or somebody on birth control pills, or any kind of estrogen hormone replacement. Pregnant people, and especially multiparous women, are going to be at risk. When I worked in the PACU, we often did cholecystectomies on pregnant people, and I would have to listen to fetal tones in the PACU. So, life-threatening complications of cholecystitis include biliary colic, choledocholitis, and that refers to a stone in the common bile duct because that can result in cholangitis, and I always want to put an extra syllable on that word. So, cholangitis is like an acute inflammation of the bile duct, and the patient is going to have a sudden fever, suddenly turn jaundice, and pain in the right upper quadrant of the abdomen. So you have to kind of recognize those three signs because that is an emergency and it happens rapidly. Choledocholitis, so for some reason a stone gets stuck in the common bile duct. And the pain of cholecystitis, it is abdominal pain, and it can be mild to severe, intermittent to constant, and it could have radiation to the right shoulder. Anytime we have radiation to the right shoulder, we call that referred pain. Usually it travels like on a nerve up to where the area is. So in this case, the gallbladder is in the right upper quadrant, and the patient may present with pain in the right shoulder. So usually patients with cholecystitis are going to complain of indigestion and pain after eating fatty foods because when you eat fatty foods, it causes your gallbladder to contract. So the symptoms after you eat fatty foods, if you have cholecystitis, are all the GI symptoms like nausea, vomiting, flatulence, dyspepsia, eructication means burping, and anorexia and feeling full. Whether it's acute or chronic, cholecystitis patients are going to present with a fever. They could have Bloomberg sign, and that is just refers to rebound tenderness when the provider palpates the abdomen. And Murphy sign is pain with palpation of the gallbladder. Okay, and the provider elicits that, but that's kind of when you hear Murphy sign, it means inflammation of the gallbladder. You're going to need to know the PQRST pain assessment that you learned in fundamentals, so kind of remember that. So you want to know what's causing the pain, and usually it's eating a fatty meal, quite honestly, that is causing the pain. And what makes it better? Not eating, usually. The signs and symptoms of chronic cholecystitis. Okay, this is due to like biliary obstruction. So I talked about the clay-colored stools. They'll have fever because it's inflammation, jaundice, steatorrhea. Okay, because the bile helps us digest fat, it's going to lead to steatorrhea, which are those fatty stools that smell really bad. Okay, they're going to have itching and burning sensations on the skin, and that is due to having an increased bilirubin because it can no longer flow through the bile ducts. Dark and foamy urine, and history of intolerance to fatty foods. So they could have calcified gallstones, and you'd see that on an x-ray. Some other testing includes an MRCP that I think, just think of that like an MRI of the gallbladder. And remember, when you have an MRI, the dye they use is not iodine based. So you don't have to ask about an allergy to shellfish. And you really don't have to ask about that anymore, yet some of the textbooks and some of the questions still do refer to asking somebody if they have a shellfish allergy. And so it is a dye, so it can hurt the kidney. So you're going to hold the metformin to prevent lactic acidosis 24 hours before and 48 hours after. And the patient needs to be NPO. ERCP is both diagnostic and it will treat as well. Okay, so it stands for endoscopic retrograde cholangiopancreatography. So they may do that with somebody with cholelithiasis to see if the patient has biliary obstruction because they can extract stones. A HEDA scan, they may do that too. That's a test that you get in nuclear medicine. The patient has to be NPO before that. That's the big deal about that. The best test is the ultrasound of the right upper quadrant because it's the least invasive out of all those tests. What lab tests are affected? Elevated WBC. Okay. If the pancreas, say there's biliary obstruction and the pancreas gets involved, you also have an increased amylase and lipase in addition to the elevated liver function studies. Pain is managed by avoiding fatty foods, explaining that to patients. Hydromorphone and morphine, they may increase spasms in the sphincter of Oddi, but that's if they have severe pain, that's probably what you're going to give. In the old days, we didn't give those medications. We used to give meperidine, which we can't give anymore. So we're kind of limited on what we can give patients. Ketorolac also can be given. Um, can patients experience anorexia? Yes, that is one of the GI symptoms could experience. The big thing about the diet that you're going to recommend in cholecystitis is the low fat, okay? Because fat is what triggers the colic. It triggers the gallbladder to contract. To monitor for nutrition, the best lab is prealbumin. If that's low, it could indicate. And prealbumin is shows a snapshot of acute, like within the last 72 hours, if somebody's becoming malnourished. There are medications that patients can take to dissolve gallstones. It's going to take a little bit of time, and this would only be for patients who cannot undergo surgery. So the signs and symptoms of severe biliary colic are shock-like symptoms, right? They're going to have shock-like vital signs, so tachycardia. They're also going to be pale, diaphoretic, and suffer from extreme prostration, which means exhausted, okay? The interventions, you're going to call your rapid, you're going to stay with your patient, you're going to keep the bed flat and anticipate the need for IV fluids to treat the shock. And don't give opiates or sedatives until they're evaluated by a provider. And then eventually, when the dust settles, you'll have to call the provider as well. Usually, because the physician, if you have one in your rapid team, is not going to be the same physician as the one the patient has, okay? Lap chole, very common surgery. Let me see, let me just hit some highlights. With lap chole, because of where the incisions are, even though it's lap, patients have a hard time with deep breathing. It can hurt, so you have to really be on them to turn, cough, deep, breathe. Anytime if they had an open or anytime somebody has surgery on their abdomen, you're always going to roll them over to check for blood pooling, to make sure they're not bleeding. And then usually patients return to their normal function within a week. Some surgeons will not let them have like sodas or drink from straws because it produces gas. But the big thing again is the low fat diet and also introducing fatty foods one at a time. Complications from the lap or open chole, I just went over that. That's like your pneumonia. Because of where the incision is, they don't want to turn, cough, deep, breathe. If somebody complains of pain in the shoulder or thorax after having cholecystectomy, especially laparoscopic, that's what I'm talking about. It's the gas from the surgery, so they need to get up and move around. That is the best treatment for that. They can use a heating pad as well in this case. They may have a JP if they have an open gallbladder surgery and a T tube. Okay, so with the JP, you would expect the drainage to be serosanguinous and it may be stained with bile for the first 24 hours. The T-tube is a gravity tube that is inserted into the common bile duct, and I'm going to show you a picture. Since it's a gravity drain, you have to make sure it's draining and it's not kinked up. So you expect golden to dark green color of the bile. It's going to put out 500 to 1,000 mLs per day. You never irrigate or aspirate a T-tube. And then a decrease in T-tube drainage could mean there's kinks and the patient's lying on the T-tube. So make sure it is unobstructive, and it probably will remain in place. Like when I first came into nursing in 1987, all gallbladder surgery was done open, and patients were in the hospital for a long time because they had this T-tube. But usually it's going to stay in until the edema subsides. It's put right into the common bile duct. Let me open this up. So here, this is why we call it a T-tube. It's T-shaped. So this is the common bile duct. And what happens is if somebody has an open cholecystectomy, they take the gallbladder out. So all this area is going to be extremely edematous. So the liver produces the bile, and it's going to travel down the hepatic ducts to the common bile ducts. So this is so that the bile can get out. That's why they put the T-tube there, and it's to gravity drainage. And this is what it looks like. And they use them after liver transplants as well. Um, and if they go home with it, they need to report an absence of drainage with nausea and vomiting, because that means obviously it's obstructed. And then the considerations, you're going to monitor for peritonitis. It needs to be flowing, or I should say putting out bile. And peritonitis, you're going to see a fever. They're going to have guarding, extreme abdominal pain, rigidness, and shock-like vital signs. Okay, so that's it for cholecystitis.